In this next section, we'll talk about several different other causes of kidney dysfunction. These include infections, vascular disorders, and obstructive uropathy, which leads to kidney dysfunction. Let's talk about the infections first. Now, infection of the urinary tract can occur in two different ways. The most common way is an ascending infection from the bladder to the kidney. The most common causes of this are the common causes of urinary tract infections, things like E. coli, Proteus mirabilis, and Klebsiella. You can also get this from the normal flora, the gram-negative flora of the colon. The other way that you can get infections of the urinary tract are actually hematogenous spread of staphylococcal or E. coli infections from other sites in the body. Now, this is most commonly occurs in women, especially during pregnancy, when they tend to get lots of UTIs. Predisposing factors are the same as those for urinary tract infections. Things like obstruction, which we'll describe a little bit later. Indwelling urinary catheters provide a nidus for infection, which can lead to pyelonephritis. And also congenital abnormalities of the urinary tract, which cause it to flow in the opposite direction, what we call reflux. Now, clinically, what you see is cystitis, which is infection of the urinary bladder. And this manifests itself as urinary frequency, as pyuria, which is white blood cells in the urine, and hematuria, which is red blood cells in the urine, but no white cell casts. White cell casts are reserved for pyelonephritis, where you actually get white cells up in the tubules of the kidney, and that's what produces those white cell casts. Pyelonephritis is more severe. You see all the manifestations of cystitis or bladder infection with the addition of high fever, flank tenderness, which we call costovertebral angle tenderness on physical exam, urinary white cells, and white cell casts in the urine. Here's a schematic diagram of the two ways that you can get a urinary tract infection. Again, you can get it ascending from the urinary bladder into the kidney, or you can get it hematogenously via the vascular tracts. So what are complications of urinary tract infections? People who get pyelonephritis or infection of the kidneys can develop what we call papillary necrosis. Now, the renal papilla is the very tip of the renal medulla, where all the collecting ducts come together and empty into the urinary tract proper. What happens here is you get necrosis of the medullary pyramids, the papillary structures that empty into the renal pelvis. And this resembles infarction and can cause kidney dysfunction. You also get pyonephrosis, which is suppurative or pussy exudates, which fill the renal pelvis, the calyces, and the ureter. You can also get perinephric abscesses, which is when the infection actually breaks through the renal capsule and forms an abscess in the perinephric tissue. Now, one of the things that will set you up for a urinary tract infection is what we call reflux nephropathy. Reflux nephropathy is where you get backflow of urine from the urinary tract in the reverse direction to the kidneys. This is one of the most common forms of chronic pyelonephritic scarring. Now, places where you can get this are in vesicoureteral reflux, where you get reflux from the bladder into the ureters, or intrarenal reflux, where you get reflux from the ureter into the kidney itself. Now let's talk about some of the vascular diseases of the kidney. We'll start with a clinical vignette. This is a 30-year-old female that presents with primary hypertension. You do a physical examination, and you notice that she has an abdominal bruit or a bruit over her abdomen. So seeing that prompts you to do a renal angiograph, which reveals renal artery stenosis that has a characteristic string of pearls type appearance. This is characteristic of a disease that we call renal artery stenosis. Basically, this disease is anything that causes a decrease in the caliber of the renal arteries. This occurs basically in two settings. One is what we call fibromuscular dysplasia. This is the type of renal artery stenosis that we see in young women. It's an idiopathic disease that's characterized by a fibromuscular thickening of the intima media and or adventitia of the renal artery. The second setting in which you see renal artery stenosis, and the most common setting, is atherosclerosis, where you get atherosclerotic plaques in older individuals who have long-standing vascular disease. Clinical manifestations, or the pathophysiology leading to the clinical manifestations of this disease, are as follows. What happens when you get stenosis of the renal artery is you get decreased blood flow to the kidneys. This is detected by the juxtaglomerular apparatuses we've described in the endocrinology lectures, and that activates the renin-angiotensin system. basically the kidney thinks that there's hypotension, that there's hypovolemia, and that activates the renin-angiotensin system, increases aldosterone production. The aldosterone production acts on the kidney tubules to increase sodium reuptake and increase potassium secretion in the renal tubules. This leads to increased volume and hypertension. It can also result in hypokalemia with the resulting cardiac arrhythmia and other complications. Here's a picture of what fibromuscular dysplasia looks like. Here is, again, a fibrous proliferation in the intima of the renal artery, leading to constriction of that artery. The media also shows this as well. And the lumen then is stenotic. It gets very small. Another type of disease that you can get in the vasculature of the kidney is what we call benign nephrosclerosis. This is sclerosis or hardening of the renal arterioles and small arteries, leading to focal ischemia of the renal parenchyma. Risk factors for this include chronic hypertension and diabetes mellitus, and we described this a little bit in the vascular pathology lectures as well. In this, you get thickening of both the tunica media and the intimal portion of the arterioles, and you get hyaline deposition in the arterioles. In hypertension, this is from proteins being pushed out of the plasma into the tunica media. In diabetes, this is again from non-enzymatic glycosylation of proteins, which get deposited in the walls of these arterioles. If this happens over a long period of time, you can actually develop renal failure and uremia as a consequence of this, because you get repeated focal ischemia of the kidney. Here's a picture of what this looks like. You get hyaline or glassy eosinophilic deposits in the tunica media and the tunica intima, and that causes marked thickening of the walls and a narrowed lumen. You can imagine that these arterioles don't carry blood very well, and that's what leads to the focal ischemia of the kidney parenchyma. Now, there's another type of nephrosclerosis that we see with malignant hypertension. This is acute hypertension greater than 200 over 100 that leads to severe and rapid progression of disease. The pathogenesis of this is fibrinoid necrosis, endothelial injury, and platelet deposition within the arterioles of the kidney. You also get an onion skin proliferation of the muscular layers of the kidney as well. Clinical manifestations of this are papilledema, which you get in the eye, encephalopathy from decreased blood flow to the brain, and renal failure from acute necrosis of the renal parenchyma. Here's what it looks like. You get fibrinoid necrosis, which again is this pink eosinophilic stuff in the wall of this arteriole. And you can also see, though it's not shown here, but in the vascular pathology lectures, you can also see this onion skinning muscular proliferation as well. Now, you can also get renal dysfunction, renal vascular disease in the thrombotic microangiopathies. And we talk about these diseases at length in the hematology lectures and the coagulation lecture particularly. But in brief, these are groups of disorders that cause thrombosis in capillaries diffusely throughout the body. What you see in these diseases is microangiopathic hemolytic anemia, that is red cells being broken up as they try to traverse these small clots throughout the vasculature. You get thrombocytopenia because the platelets are consumed with these small clots. And you can get renal failure because these small clots lead to renal ischemia because of blockage of the renal microvasculature. Now, there's two basic types of thrombotic microangiopathies. There's the hemolytic uremic syndrome, and there's thrombotic thrombocytopenic purpura, or TTP. In both of these diseases, what you can see is fibrin platelet complexes within the capillaries of the glomeruli. In this particular picture, what you're seeing is fibrin stain, indicating the formation of fibrin-rich clots throughout the vasculature of this glomerulus. Hemolytic uremic syndrome usually occurs in children and often occurs after infection with a particular type of E. coli, what we call enterohemorrhagic E. coli, or E. coli 0157H7. So they'll get a GI or a flu-like syndrome followed by the production of Shiga toxins, Shiga-like toxins by this E. coli. This leads to the sudden onset of bleeding, severe oliguria, and this microangiopathic hemolytic anemia. Some patients will develop neurologic changes, though this is less severe in hemolytic uremic syndrome than it is in TTP. In TTP, this is caused by a genetic defect or an acquired defect, maybe autoimmune, in a protein called ADAMTS13. And we describe in the coagulation lectures how this leads to TTP, so I won't talk about that now. But the basic consequence of this is, again, the diffuse formation of small clots throughout the microvasculature of the body. This results in a pentad of features including fever, microangiopathic hemolytic anemia, thrombocytopenia, neurologic changes, and renal failure. Now, you can see that many of these features overlap with hemolytic uremic syndrome, but the neurologic changes are more common in TTP, and the renal changes are less common relative to HUS, where you have less prominent neurologic features and more prominent renal features. Another vascular disease that you can see is sickle cell nephropathy. And again, we discussed sickle cell disease at length in other lectures. But both in the homozygous and heterozygous forms of this disease, you can get the formation of obstructive vasculopathy leading to ischemia and renal dysfunction. Problems in this disease include hematuria, diminished ability to concentrate urine, meaning that you get polyuria, increased urine production that is dilute. You can get patchy papillary necrosis, again from obstruction of the microvasculature, and proteinuria that results from the death of renal tissue. These are the vascular diseases of the kidney. Now, the third category of diseases that we'll talk about in this section are the urinary obstructive diseases. Now, obstruction of the urinary tract system can occur at any point in the system. You can get obstruction of the renal pelvis from tumors, from big stones, from strictures in the junction, the uretropelvic junction. You can get obstruction in the ureters, again from stones or tumors, from clots, from strictures of the ureter. You can get vesicular-ureteral reflux, which is reflux again from the bladder into the ureter, which again causes obstruction. You can get calculi or stones or tumors in the bladder, which can block flow. You can get swelling or enlargement of the prostate, like benign prostatic hypertrophy or prostatic carcinoma, which block the flow of urine through the prostatic urethra. Or you can get urethral strictures, tumors that block urine flow in the urethra itself. The consequence of this is enlargement of the kidneys. Urine, which normally should flow unobstructed from the kidney through the ureter to the bladder and out through the urethra, backs up. And this causes everything in the system to dilate. So you get dilation of the renal pelvis, dilation of the calyces. You can get interstitial inflammation and atrophy of the tubules with interstitial fibrosis as a consequence of this swelling, dilation, and obstruction. Clinical features of this, you see hydronephrosis on ultrasound. This is expansion of the renal pelvis that is clear on a renal ultrasound. Here's a picture of what it looks like. You can see in this kidney that the normal kidney parenchyma, that is the cortex and the medulla, are shrunken, and the pelvis and the calyces are enlarged. And you can imagine as you compress all of the renal parenchyma that this will gradually lead to dysfunction of the kidneys. Now, another cause of obstruction is urolithiasis. This is the production of stones in the urinary tract. This occurs more commonly in men than in women and is usually caused by supersaturation of some substance in the urine. This leads to crystallization, which forms a nidus then for stone production. Now, there are several different types of stones. The most common of these are calcium stones, either calcium oxalate or calcium phosphate or both. This occurs most commonly in individuals that have some type of hypercalcemia, be it from hyperparathyroid syndrome, from malignancy, from sarcoid, from vitamin D intoxication, or what have you. The unique feature of calcium stones is that they are radiopaque, meaning if you take a KUV, an abdominal X-ray of this individual, you will actually see the stones because they show up on the X-ray. The rest of the stones that we'll talk about are radiolucent and you don't see them. So this is one way that you can distinguish between these different types of stones. The second most common form is an ammonium magnesium phosphate type. These are radiolucent. and usually occur because of excess alkaline production by ammonia-producing organisms like Proteus mirabilis, a frequent cause of urinary tract infections. So what you see are people who have frequent, repeated urinary tract infections and pyelonephritis from Proteus mirabilis will have alkalinization of their urine, causing precipitation of magnesium phosphate and ammonium, leading to stone formation. The characteristic type of stone that you see in this disease are these large staghorn calculi, which are basically casts of the renal pelvis that form within the kidney itself. The problem with these is they're very difficult to pass because of their large size. A couple of different types of stones that you can see. Uric acid stones are seen in individuals with hyperuricemia that we already described, people that have hyperuricemic gout, or who have leukemia and myeloproliferative diseases and are treated with chemotherapy. These stones are basically uric acid crystals, which form stones. They're radiolucent, so you can't detect them on X-ray. You also see cystine stones in a disease which we already talked about, which is cystinuria, where you have a genetic defect in renal reabsorption of cystine. And this leads to crystallization of the cystine formation of stones, which again are radiolucent. And this ends the section on miscellaneous diseases of the kidney, including infections, vascular diseases.